Hello and welcome to our Impact with Aegis series. Today we're going to be talking about telehealth. My name is Shyla Hamrick. I am going to be monitoring the questions section. We will have time for questions throughout the course. So if you do have any questions, please go to the questions feature on your panel, and we will try to get to all of them. Today, Janice Brown will be our moderator, and she will introduce the panelists here in just a few moments. First of all, I just want to go over a few housekeeping items, and then I will hand it over to her. Occupational therapists and OTAs are required to pass a post-test quiz within 1 week for credit. After this class, a link will be emailed to all the OT and OTAs tomorrow, and the speech pathologists are required to submit an Asha bubble sheet. This is only for speech. The Asha bubble sheet is located in the handout section. You can download the brochure and the Asha bubble sheet there. If you have any questions, you can email me. My email should be shown on your screen. And if you have any questions, just type them in the questions feature. And with that, I will leave it to you, Janice.
All right, thanks, Shyla. Welcome, everyone. I'm Janice Brown, Clinical Practice Specialist for Aegis Therapies, and I'll be your host for today's call. Today, we're going to spend the next hour hearing from a group of panelists that are actively engaged in telehealth. Telemedicine or telehealth is not new, and it has expanded exponentially in the last decade as technology has improved. So while it's not a new mode of service delivery, the pandemic resulted in making telehealth more available and necessary for patients requiring rehab services. However, many clinicians are unfamiliar with the process or the practical realities of providing therapy via telehealth. So we hope that the information provided and the experiences shared by the panelists can give you the answers you need to get started with telehealth, or if you're already doing telehealth, to make you more confident in that mode of service delivery. We have a set of questions for the panelists, but as Shyla said, she'll be monitoring the chat feature to answer your questions as well. As we get started, feel free to send in your questions via chat. And if you would like your questions directed towards a specific discipline, then please indicate that in the chat as well. So we'd like to start by having our panelists introduce themselves. So why don't we go ahead and start with our PT, and that would be Barb.
Hello, everyone. My name is Barbara White. I am a PT and also the Director of Rehab Telehealth for Aegis Therapies. I've been providing telehealth services for skilled nursing facilities and outpatient clinics since the COVID-19 nationwide public health emergency in 2020.
Okay, thanks, Barb. And then for OT, we have Stephanie.
Hi, my name is Stephanie Schild. I am also a clinical practice specialist with Aegis. I've been with the company 20 years, but practicing in the subacute space for the past 26 years. And also, just like Barb had mentioned, I have been actively engaged in telehealth practice since March of 2020.
All right. And for speech, we have Lucy.
Hi, my name is Lucy Nelson. I'm a director of rehab and a speech language pathologist by background, and I have both provided telehealth services and managed clinicians who provide telehealth, and was fortunate enough to work in a work group that helped kind of develop a division of telehealth so that we could kind of stay on the cutting edge as a company with this mode of service delivery.
All right, guys. Well, let's get started, not waste any time. I'll direct the first question to Stephanie. Can you describe the difference between telehealth and in-person treatment?
So when I think of telehealth and in-person treatment, the only thing that is actually different is the location of the clinician. Everything else, for all intents purposes, is the same. That treatment session still must require the skilled services of an occupational, physical, or speech therapist. We're involved and engaged in clinical observation, assessment, and analysis of the patient. And much of the skills that we provide as a clinician happen behind the scenes, kind of in our mind. It doesn't always happen physically with our hands. So that might be the one thing that we would be missing out on with telehealth, is that ability to get, hands on the patient. But for all intents purposes, everything else is exactly the same, that clinical analysis and assessment of that patient.
Okay, does anyone have anything else to add to that? And Shyla, just jump in there if there's a question that directly relates to the subject we're on.
Okay.
Okay,
There is a
go ahead.
question. How are you doing bedside swallow evals through telehealth? We don't have an assistant, so who are you having in person?
Can we save that one? Because I
Sure.
think we're going to hit that topic a little further down. And Lucy,
Sure.
can you keep that in mind, that question? Okay. All right, a little bit more into the basics. Barb, who can provide telehealth services?
Your eligible clinicians are going to include your physical therapist, your occupational therapist, your speech language pathologist, as well as your physical and occupational therapy assistants under appropriate supervision. However, it is important to examine your state licensure law and corresponding state licensure board regulations and rules, because in many states, the Practice Act is silent on the use of telehealth. So if this is the case in your state, you may wish to contact your state licensure board to ensure that there are no limitations or restrictions for practicing telehealth.
Okay, very good. And Stephanie, what are some of the requirements for telehealth as far as CMS goes?
So all of the basic requirements for an in-person treatment apply when we're providing telehealth. So making sure that we're following that HIPAA protection. As far as CMS goes, when we are utilizing telehealth, it's absolutely required that we have virtual, live, real-time interaction between that patient and that client. There needs to be that two-way audio and video communication. Nothing can be delayed. You need to make sure that you're obtaining consent prior to the treatment session and that is also documented. As Barb mentioned, you want to make sure that you refer to your State Practice Act for specifics related to telehealth. Typically speaking, you need to be licensed in the state where the patient is located. However, some states do require that you, the clinician, be located in the same state as the client in which you are treating and delivering services. The other thing that may vary by state is some states do require actual physical written documentation, so a physical consent form be signed prior to that telehealth visit. So again, make sure that you reach out, look at your local state practice acts if there are any specific requirements related to telehealth, and then follow that two-way audio video communication.
And Barb, I know that during the PHE, the government was more lax with what platform could be used for telehealth, but that changed when the PHE ended. So could you talk a little bit about that?
Sure, absolutely. So just as you mentioned, it's really important to revisit that the HIPAA enforcement discretion that was exercised throughout the COVID-19 public health emergency has expired, okay? So currently, all telehealth services provided by covered healthcare providers and health plans must comply with the HIPAA rules. So covered healthcare providers and health plans must use technology vendors that comply with the HIPAA rules and will enter into HIPAA business associate agreements in connection with the provision of their video communication products or other remote communication technologies for telehealth. So some current popular HIPAA platforms that are HIPAA compliant would include Doxy or Zoom for Healthcare or Microsoft Teams, but definitely not FaceTime. So they're no longer lenient as to what platforms you can use. They must be HIPAA compliant now.
And Stephanie, what do I specifically need to document when I do a telehealth visit?
So when we're providing a telehealth visit, it's important that we attach that 95 modifier to any CPT codes that we deliver, designate that that service was delivered via telehealth. And then your documentation is going to be really no different than it would be if you were doing an in-person treatment. You want to make sure that you have that skilled documentation that speaks to the services that you delivered, any clinical analysis or assessment that you completed with the patient. And then finally, there should be a clause in there about that patient's consent to participate in that telehealth visit as well.
All right, Shyla, did we have any questions that relate to the information we just went over? Because we're about to get to where we can answer that speech question.
Okay, I do have a question. I'm not sure. I was informed that in Texas, insurances are not going to approve telehealth sessions by the end of the year. What do you know, or what can you share about this?
So
Who
I'll go
wants to speak to that?
So most of the things that we're speaking of are related to CMS standard policy and regulation. We obviously know that private insurance companies can have their own twists about what are covered services. So if you're hearing something about a specific provider or coverage plan, it would be best to reach out to them to see what their criteria are, because it's not going to be the same across the country, necessarily state to state. And there's so many different insurance policies out there today than there were even 5 or 10 years ago.
And that's a good point, because I know, just like you said, they're all different. And if they're a Medicare replacement plan, they are supposed to follow CMS's guide. But if they're a different animal, they kind of can make their own rules. So it's possible. I certainly have not heard anything about it. And Barb, have you heard anything?
No, I haven't. Mm-mm.
Okay.
Yep.
I have one. Can you repeat the 95 code that you stated in your note?
Yeah, so in order to designate that a visit there needs to that is delivered via telehealth, you have to have a modifier, and that's the 95 modifier, which all it's stating is that that service was delivered via telehealth.
And depending on what platform you're using, in NetHealth, there are drop-down boxes where you choose asynchronous, and that will automatically create the 95 modifier, but it just depends on what you're using.
How do you get consent for patients that aren't their own responsible party?
Who wants to take that one?
I can take that one, and because that's happened in multiple cases for telehealth visits that I have done in the past. So if you have that cognitive patient, let's say, for instance, in a long-term care facility who cannot give the consent, and you know that they can't give the consent because perhaps they have that advanced stage dementia, then you're going to be contacting their power of attorney, or the responsible party, and you would have them consent that you can do the visit with their loved one, or if that's just a friend. In the case, I also have done a couple special needs pediatrics where we've gained consent either from social service or the facility administrator, because she's acting as the responsible party for that patient in the facility. So if the patient can't give it, you just simply reach out to the responsible party or power of attorney, and you can gain it there. That being said, I would absolutely make sure that you document that in your daily note, that that's who you gained that consent from.
Anything else on that, Shyla?
No, that's it.
Okay. So Lucy, on to speech. Please tell us what you think is important to remember when you're developing a process for providing telehealth. Now, Aegis, we have some processes set up, but if someone didn't have one, and then maybe you can also address the helper issue.
Sure. It's very important to have predictability and routines. So those routines assist the helper in keeping their day running smoothly, and in addition, keeping pre-session communication to a minimum. A few ideas for best practices: read your notes prior to getting online. I usually start to make contact with my helper, whether it be a rehab specialist or another clinician, by checking PCC for orders, and I look at nursing documentation regarding the patients, in particular those that have had like a recent diet change, or if there has been any aspiration documented. You also want to provide your helper with a list of materials. So upon contacting my helper, I may provide a list of materials that may be needed, such as a snack if we're going to do a therapeutic trial, nectar, stimulus cards, cognitive materials, that kind of thing. Stop by the nurse's station. We usually begin treatments by stopping by the nurse to speak with them and get any information related to that might not be documented. In particular, if you have someone who's on a feeding tube or a trach, you want to be as thorough as possible with those patients. And then perform treatments in an order that benefits the helper. So we perform treatments sequentially and often as efficiently as possible, with evaluations saved for last, so that the helper can get back to their own caseload or their own job duties. And then that's when I write my reports. Progress notes are often written while the helper is facilitating the treatment, so kind of point of service, and while we're doing maybe a trial or an expressive language task. And then lastly, you return to the therapy gym and give the DOR the info. So at the end of the treatments, we return to the gym. This is where we can access the DOR, make requests regarding any communication, say in morning meeting, and get information regarding anticipated admissions, discharges, and that kind of thing.
Okay, and Shyla, can you repeat that question again?
Sure. How are you doing a bedside swallow eval through telehealth? We don't have an assistant, so who are you having in person?
In my experience, I'm typically using a rehab tech, but if you don't have one, you're probably going to have to rely on another clinician of a different discipline. And I know that's hard because we have limited time, but you can't use your facility staff. They typically, it's got to be an Aegis employee that's working alongside you. And then they, especially if you could grab an OT and they can be working on something like positioning or an ADL task while they are helping you, then they could essentially be co-treating or co-evaluating.
Yeah, and on the OT scope of practice, they can deal with dysphagia as well. So that person would probably be best suited to follow the directions given by the speech language pathologist. Do you agree with that, Lucy?
Yes, absolutely. And I think that's why the OT example came so readily to my mind. That's who I would default to if you have an OT that's accessible to you.
Right.
We have a question. You can do co-evaluating and co-treating over telehealth?
Barb, do you want to take that one?
Sure. So if you are doing, okay, so I'm going to give the example that you have an OT on site doing an evaluation, and either PT or speech is off site as a telehealth therapist. also doing an evaluation, okay? So essentially, OT is the helper throughout some of that evaluation. Once that whole process is complete and OT has the information they need and speech or PT have the information they need, both of those disciplines cannot bill that entire time, okay? That time needs to be split up properly and ethically depending on at what point in time was the OT performing a skilled service and at what point in time was the speech performing a skilled service. And those services have to be divided up and billed appropriately. So essentially, no, you cannot co-treat an eval in my, that is my understanding of it. Now, as far as a visit goes, that can be a true co-treat, although I think in most circumstances that it's not best practice. I think in circumstances where you have no other options, that it could be an option where the OT, if this is a Medicare Part A patient, okay, then you'd be looking at co-treatment. Now, for a non-skilled patient like a Part B or an HMOB, and I just want to be specific on that, disciplines can't co-treat at the same time. That has to be split time. So this would be in reference to a skilled patient, a Medicare Part A or a managed skilled patient. If they are performing the telehealth visit and the on-site therapist is an OT and doing a skill with that patient, and the PT is off-site doing a skill with that patient, and both skills, it's ethical that both skills are being performed at the same time, then that could be essentially billed as a co-treatment. And Janice, correct me if I'm wrong on that, but I'm pretty sure that's accurate.
Yeah, it's a very, I would say, far in between that I would do a co-treatment. You agree, Stephanie?
Absolutely. I think the thing that's really super important to remember is that all the rules, the letter of the law, the definitions are the same whether you are doing an in-person treatment or you're doing a telehealth visit. And when we talk about a co-treatment, the guidelines are very specific, and we have to speak that it was to the patient's benefit, not to the clinician's benefit for time, that those services were delivered adjunctly, and that the differing disciplines were performing unique and different components related to the services. So, like in person, very easy to justify that maybe PT is working on a balance task while speech is working on a cog task, to focus on dual attention, that thinking and moving at the same time. So you want to be very clear and very certain that everything that you're doing is meeting the letter of the law, if you will, or the definition.
Okay,
Yep,
so
good point.
just to confirm what you said, if OT helped with a swallow eval, then OT would just be a helper, not a co-treatment eval.
Correct. Yep. And I think it's something we maybe just want to move ahead about the helper right now, Janice, because there's a lot coming up about the helper right now. So just want to be very clear. There is no requirement anywhere for telehealth, nor has there been in its entirety, that anybody be present with the client that's receiving services, okay? However, one of the things that our company has taken on is that, it is best practice, as Lucy was saying, to have somebody there with the client for safety reasons, because there's a lot of concerns that a clinician providing telehealth service can have, or maybe the patient isn't totally understanding what's being asked, and that facilitator or helper there can help facilitate that visit so that the observing or treating clinician can get the data that they need. So there is no requirement for a helper, but it is up to the individual clinician to choose a helper that will help facilitate that session. So not only so that the patient is comfortable and the facilitator, the telehealth provider, feels comfortable delivering those services. Speaking for myself, I have had registered PTs, PTAs, I've had CODAs, I have had speech therapists help me with the telehealth. I've had a director of nursing help me with the telehealth. And I will just say that experience didn't go quite as well. As I think Janice brought up, you know, the lingo and the language that we speak, it's a little bit easier to work directly with another therapist as opposed to somebody outside of the world. It can be done. And then I've also worked even this week, just yesterday, with a rehab tech. So not a clinician, but somebody who has some experience and knowledge of the therapy world. And I can say those visits went very, very well.
Does the telehealth evaluator have to be willing to travel to the center if there's an issue or challenge with the patient?
No, because sometimes it's just not an option. Like myself, I do telehealth in the state of Oregon sometimes, so very difficult to do that. So if there is an issue or concern, you're gonna follow your best clinical judgment. Is that reaching out to who's gonna be the primary on-site treating clinician? If I'm the OTR, maybe I'm gonna reach out to the RPT. So they can maybe follow up on something that I have a concern, or the director of rehab. And if necessary, maybe I'm going to reach out to the nursing unit if I have some very specific concerns with that patient. Obviously, I think we can all agree that in-person on-site treatment is best for everybody, but sometimes access to care prohibits that from happening. You know, maybe it's a COVID outbreak and the registered clinician is out. That's going to be a temporary thing. They're going to come back. Or we've seen situations across the country where staffing is quite challenging. And without the use of telehealth services, those patients would be sitting without services at all, because who would start that plan of care? Who would oversee that patient's plan of care once it's established and provide the appropriate supervision?
Yeah, and I think just Barb, jump in if you've seen something different, but when I would review state practice acts and such, most of the time the supervision is defined by readily available by phone. You know, of course, there are certain cases where it will say direct sight, line of sight, and that kind of thing. But that's why you got to check your state practice act as well, just to be certain, because we can't speak for every single state yet.
Right, but you're right on that, Janice. More often than not, the state practice acts talk about supervision as being readily available via some communication, and that is, telecommunication is acceptable.
Shiloh, was there anything else?
We have, what about billing evaluation code via telehealth? Is this billable time that is spent with patient, or can this be chart review completed prior to seeing the patient?
Stephanie's smiling, so I'll toss that one to her.
Yeah, so I go back to the statement made before. So CMS is very clear on evaluation time. It is skilled time with the patient. Even though that's a service-based code, the time that we enter under the eval code cannot include non-direct patient-related treatment and care. Okay, so that's the same whether we are in person with a patient or via telehealth. Obviously, there is a larger opportunity to do some point of service documentation if you're on site with the patient. When we are doing telehealth, that option is very limited. I can speak for myself. When I am doing telehealth, I'm trying to get the biggest bang, if you will, for my time with the patient, assess as many things. I don't want to use that valuable time to do things like, you know, maybe Therax or something that's a little bit more a routine part of treatment, really focusing on top of licensed skills, because generally speaking, there would be somebody on site that would be able to deliver those services in person.
Okay, Shyla, anything else?
So then it's fair to say that productivity standards should be lower for telehealth since it cannot be on site?
I would think, this is my opinion, I would think that it will be just as in person, it will be different, because depending on what the say it's a PT, if they do the eval, they're going to bill for that. And then many times, if it's a PTA that's working with them, they will take over. So you can work to be efficient so someone is billing. And if you're doing point of service documentation, that helps as well. In my experience, yes, it may lower the facility efficiency somewhat, but as you get better at it definitely improves. Anybody else have anything to add or contradict, even if you've seen something different?
I think just to add to that a little bit, Janice, I think that, and this is one of the things that Aegis is working hard to develop, there are some best practices to improve efficiency during telehealth. But there are so many different circumstances that surround a telehealth visit. I mean, are you referring to an evaluation, or if you're just doing a supervisory visit? No, that supervisory visit should probably be fairly efficient when compared to maybe an evaluation, or depending on if you consistently use an assistant as your helper, and in that relationship has been established between that telehealth therapist and that helper, they're going to have a really great working relationship, and they're going to already know, because they've worked so much together, what the other one wants and expects, and almost, they'll be able to tell what's coming next. And that really helps in my experience. When I'm paired with an assistant that I'm very used to, I can do quite a bit point of service, especially if I have a split screen going, or I've called in through my phone or my tablet and my laptop is available for me to be typing on while I'm watching, and giving some cues to the assistant to gather that objective information so that I can complete that evaluation. So there are so many different things, but yes, I think that for newer clinicians that are doing telehealth, you can expect the efficiency to be a bit lower. But I think that there are a lot of best practices out there that we as clinicians need to embrace so that we can be as efficient as possible when doing these telehealth visits.
And you know what? That's a good segue into this next question. It all ties together. So the question really is, who do you get to facilitate on site, which we've talked a little bit about it, but what does that person need to know before this session? And so, Lucy, why don't we start with you, and then Stephanie and Barb, you can add in anything that might be different for your disciplines.
Okay, so my experience as a speech language pathologist has been to work with departments who have lost their SLP or otherwise have been unable to gain access to an on-site therapist. So those treatments have often been to support departments that are already stressed for labor and services. So it's been my approach to kind of minimize the stress and labor my assistant causes the department. So generally, the DOR has already identified that helper, and then you prepare your helper. So as an SLP, the helper is likely to be a PTA or a CODA, and they may not be familiar with the practices as a speech language pathologist would be. So you have to prepare your helper prior to the session just to help you avoid any awkward or inefficient conversation with the patient present. Discuss the telehealth treatment times with your helper prior to the beginning of the telehealth services, and establish an estimated time to begin and communicate. So communicate if those times must change, and then, make sure that you're providing regular contact with the helper, and that allows them to kind of be more efficient and schedule their day. You also want to provide your helper with protocols and forms prior to the meeting. So if you were going to administer the slums, you would want to make sure they have those materials, train them in the administration of the assessments. And it doesn't have to be a really long training, just kind of hit the high points. And often patients require cues from the helper that are more effective than cues from you as a telehealth therapist. So the helper kind of must know what's happening in order to be of assistance. Have a concise list of the materials that you need and provide them with that list in advance. And also prepare yourself. So you want to make sure to ask your DOR to help you gain access to whatever your EMR is, if it's point click care. And so you can make sure that you're prepared and are able to do what's required of you for your job that day. Read pertinent information regarding the patients you'll be treating. So do a thorough chart review, and especially if you've never met that patient before. And I read the most recent nurse notes. I look at the POC and any recent therapy notes. The helper is also a great resource for understanding the undocumented kind of subjective parts of that patient, and will kind of be able to brief you on the expected treatment session as well.
Okay, and Stephanie and Barb, anything to add?
No, I think that the big thing is like Lucy said, it's about having processes, procedures, and a plan but ahead of time. The staff that I work with, regardless of the discipline that they are, they've worked with me for long enough. They know exactly, like if they show up for a telehealth visit, what I'm going to ask. I'm very methodical and pretty regimented in the tests and assessments and the processes that I put into play when I'm doing that evaluation, because again, I'm trying to gather as much information about that client, be very efficient and respectful. In our area, telehealth visits take priority above everything else. So the staff that I'm working with know if I sent out a Teams invite and we're doing a telehealth at 10 o'clock, the expectation is that they are there at 10 o'clock in the patient's room, have the patient in a gym, HIPAA protected area, that they're there and ready to go, that we're not traveling down the hallway trying to log into DoxyMe or Teams, that platform, because then connectivity gets disrupted. So it's really about setting yourself up for success. Having the phone number of that individual that's helping you out, because there are times that things happen to technology. We've lost audio. And again, the requirements are two-way audio video communication. So sometimes that means we're on our laptop with the video and we're on our phone having that voice-to-voice conversation so that we don't lose any connectivity information about that patient. I do a lot of teams that send me an H&P for the patient. There's also an option if you do use NetHealth to add that into COM. So I can read that. I work on two screens a lot of times, so I can read that H&P while I'm working with that client at that time. Sometimes I might be reviewing the PT note or PT eval if PT got in there prior to me. So it's really about having what I say methodical process when you go in. Same is true if you're doing a supervisory visit for a progress note. You know, make sure you have that eval or last progress note research up so you know exactly what goals you need to assess. And it can flow very beautifully.
Barb, you have anything to add?
I think Lucy and Stephanie did a really good job of covering that. So no, I don't have anything to add to that.
I did have what I feel is a best practice that popped into my head, and that could be having, just like a home health bag, having a sling backpack or something, because anybody that's worked with me knows that I want vital signs on everybody. And so you have all your vital signs stuff in there, goniometers, you know, my assessments should be in your tablet or your laptop, but if you needed to put papers, you would have that too. So I think that's a good idea, because there's nothing worse than getting there, oh, I don't have a gait belt, and they have to leave and get the gait belt. So you want to avoid those types of things for sure.
Hey, Janice.
Yeah.
How does the discipline helping to facilitate a telehealth visit document their time, such as a CODA helping a PT or a speech therapist to conduct an evaluation?
Who wants that one?
Sure. So at that time, that even if it is a clinician, at that time that they are the hands and feet, is what we like to call them, of the provider of care. So obvious, most of the time it's a registered therapist. They're not functioning under their clinical hat. So they're not functioning as an OTA, a PTA, or any other. They are strictly a helper. So that is non-patient related care for that individual. However, I'm just going to add, it is also a fantastic time to do, this question's coming up, but it ties in, Janice, a
That's fine.
collaboration with that individual. So for me, it's a great opportunity and time for me to collaborate and provide some supervision for the CODAs that I have working under me. And I know for a fact, because I'm out in facilities and I see it happen, even in person, on site, there's often not that collaborative time to have that conversation about the patient. What do I need to happen next? How are we going to advance these goals? What interventions do I want you to focus on? So, think about what goes on in your facilities today in person. What kind of collaboration do you have with your colleagues? So while it is non-related or non-billable patient time for that individual, there is a huge win or bonus that can come into effect with that time spent together.
I agree.
Can a family member be a helper?
Yes, we're nodding. Yes.
Yep. Yes. I actually had a family help yesterday. The clinician left to go tend to another patient, and the family member was there. So they were able to help answer some questions, help to facilitate some things until the assistant came back and finished up that treatment session. Then remember too, and Lucy, I don't know if you have some patients that are maybe more self-directed with some higher level executive function tasks. I know I had a patient yesterday, once they set her up, it was just her and I, because she was being treated more like an outpatient. We were reviewing an upgrade to her HEP. So, I mean, Lucy, you have some that...
Absolutely. And sometimes if they are really high level and you introduce a third person, it just kind of complicates things. So as long as the helper can set up the equipment, then, and I will give them direction, such as I'm just going to direct the questions, and I'll just call on you if I need you. And then they know to kind of allow me to just do the direct conversation without interjecting.
And I'll just add, use your critical thinking and clinical thinking skills. Obviously, if they're non-weight bearing and have some dementia, I'm not going to ask the family member to do a max assist first transfer ever. So just like with anything, you've got to look at the specific situation and use good clinical judgment. Shyla, do you have anything else to go along with that before we talk a little bit about ethics?
I don't.
Okay. Well, we wanted to go over this again from when we did this talk last time, about whether or not you feel it's ethical to provide telehealth in lieu of an in-person treatment. And Stephanie really pointed out and said it best, it's all about access to care. Is no care better than telehealth? Probably not. But the APTA and Asha and AOTA all have something to say about that. So I'll let each of you guys talk about that. And Stephanie, you can go first.
So again, telehealth is not new. And if you go on to AOTA's website and review the American Occupational Therapy Association advisory opinion for the Ethics Commission on telehealth, that was written before the pandemic. So again, the AOTA has very specific statements about that. And they talk again about, using, as Janice alluded to, using your professional judgment standards in order to provide the best quality care for those patients. And again, is the alternative of telehealth better than no access to care? You know, so in a lot of situations, it might be, and usually is, that registered therapist missing from the equation, but there's somebody on site who would actually be able to deliver that care on a day-to-day basis. So we wouldn't want to limit access for that patient. And then I know myself, during the heat of COVID, there were times that it was absolutely critical to deliver treatment. When we had staff out, the patient really, really needed, whether it be PT or OT or speech that day, it was critical to their care. We didn't have any other options other than to deliver those services via telehealth. So as long as we're following all the standards, protecting the patient's privacy and things like that, absolutely nothing wrong with the use of telehealth.
Okay, Barb, what about the APTA?
Sure. So the APTA, they strongly support legislative and regulatory changes that permit PTs and PTAs to provide services via telehealth, such as the expanded Telehealth Access Act. This bipartisan bill permanently lists physical therapists and physical therapy assistants as authorized practitioners of telehealth under the Medicare program. And like we've touched on before, it's all about increased access to our services. Like Janice said, is it better no treatment versus a telehealth visit? But it is ultimately the clinician involved that must determine if the patient can best be served with this mode of service delivery. So if you're out there as a telehealth therapist, that decision, I mean, you have the right to make that decision. And I can speak from experience where I have provided telehealth, and this is a difficult setting in a special needs pediatric setting where my helper was an assistant, but was not overly comfortable with being the assistant. And I was able to identify that as the telehealth therapist and say, okay, moving forward, on-site is probably best until I'm able to train her a little bit more on how to be a helper for that specific population. So that's just an example of where, as the clinician, you have the right to say, you know, this maybe isn't best for the patient.
And Lucy, what about Asha?
ASHA guidelines state that the use of telehealth must be equivalent to the quality of an in-person service, and it must adhere to the ASHA Code of Ethics, Audiology, or Speech Language Pathology scope of practice, state and federal laws, and ASHA policy.
And just like Barb said, every clinician has to use their own skill and experience and look at the patient needs and capabilities to make that determination.
Hey, Janice.
Yes.
To what extent should a therapy team prove they have attempted to secure an on-site therapist prior to utilizing telehealth?
I mean, there is no correct answer to that because telehealth is ethical and legal. So there's no rule, I'll say. Now, you may have a customer that requests it, but there's nothing that says that you have to.
Okay. Earlier, it was stated that a helper had to be a therapy employee, but then someone said a DON and family member had been used. So the helper can be anyone as long as you are using good clinical judgment.
Yes. Do you guys, I mean, agree with that? I think there may just been a little bit of miscommunication on probably the therapy member, the rehab department member would speak the language like Stephanie said and would be able to work a little easier with you, but no, a helper is not defined as a rehab personnel.
Okay. What modifier are we supposed to use for billing?
Stephanie, go ahead.
It is the 95 modifier.
Yep. Anything else, Shyla, right now?
Regarding app and type of access to telehealth, if a family refuses to load any apps onto their devices and insists on FaceTime, can we use that or not legally, ethically? This question is in regards to how it may apply in a home health setting.
No, I mean, Barb, I believe the answer is no, because it's the same for everything, right?
Yes, I believe you're correct in that it has to abide by HIPAA rules. FaceTime is not acceptable. It's not an acceptable telehealth platform now. So as a treating clinician, I don't think I would be comfortable with agreeing to do a telehealth visit without making sure that I have that secure platform, because that's the law.
What about you, Stephanie?
Well, I think I'm correct. I could be wrong. It happens once in a while. But to my knowledge, telehealth visits are not reimbursable under
That's
home health.
correct.
They can be done if it is a critical need for the patient in that visit, but it is not a reimbursable service in home health.
That's correct.
Okay.
What percentage of your practice is done by telehealth? Are you finding that telehealth is the most common practice?
No.
Oh, no.
I had to run a report for a customer just yesterday who was concerned about the amount of telehealth services being utilized in their area. It was less than 1%. And I run reports for my area every single week. And I would say even during the height of COVID, which we are in many of my buildings right now, less than 6% or around there, total services are being delivered via telehealth. So if you think about it, most of the time that telehealth service is being utilized for registry duties, an eval, a progress note, or a UPOC. So that's 1 out of 10 visits that is more than likely being delivered via telehealth. So the number I think is much smaller than many people think it might be.
And I concur with that. If you're in a small building and all you have is a telehealth PT, it's going to seem like a larger percentage, certainly. But when you take a look at the whole, I agree with Stephanie, it's much smaller than that.
What is Aegis doing about beefing up technology to ease telehealth? I know reception is a big issue and really affects the flow of the session.
Yeah, I know that, and we have people on here who are not Aegis employees, but I know that we do have different and new laptops that are going to be distributed nationally, hopefully by the end of the year, but don't mark me down as having said that definitively. But they are working towards that goal.
Yeah, and I think oftentimes it's not necessarily the technology, it is the network availability. I, for one, work with many, many, many rural facilities. Some of my facilities have a preference over Teams versus DoxyMe because of the amount of bandwidth. Some of my therapists will resort to using their phone and going on to Teams because they know in this room, I don't get Wi-Fi connectivity from the facility, but I can draw a connection off of the cell tower. So I think it's very important that you do a little bit of research in your building about where is the best connectivity. Is it on your therapy service network? Is it on the customer service? Make sure that your device is not floating between them. Again, make sure that that patient is in a static location, that you're not moving towards them. If you know that every room at the end of the hallway has poor connectivity, bring that client out of their room and into a location where you know you have better connectivity. So I think most clinicians know in their facilities where that sweet spot of connectivity is.
I agree. Anything
As an
else? Go
As
ahead.
an SLP, do you find it difficult to do telehealth for cognitive patients who are lower level with method versus in person? I find people do better in person than telehealth and seemingly more confused given the method provided for the eval.
Is that directed towards Lucy?
Is that specific to a cognitive session or just any therapy session with a patient with cognitive impairments? How about this? Can you repeat the question and then we'll
Okay.
get.
As an SLP, do you find it difficult to do telehealth for cognitive patients who are lower level with the method versus in person? I find people do better in person than telehealth and seemingly more confused given the method provided for the eval.
Okay. I do think when you have a patient that has cognitive deficits and you are introducing another type of stimuli, such as, you know, a video platform, and we're speaking to them on that. We do a lot of our sessions with older adults, and so that might be what you're alluding to with cognitive impairments, and maybe they're not used to using that type of technology, so it can present a challenge. The workaround with that is really having your helper feed them the information and have them connect directly to the patient instead of you providing that direct communication. That's what I've done. It's not a perfect science. Again, I think this has been a common theme. You may find that this particular patient is not appropriate for a telehealth service, so you just kind of have to use your clinical judgment. But if you can get the helper to carry out most of the one-to-one communication instead of it being you speaking through, like I said, the video platform, it may be a little more streamlined.
Do your telehealth evaluators usually live in the same state as the patient? What are out-of-state license requirements, and are they any different for telehealth services?
I feel certain that Barb wants to answer this question.
Right. So again, it varies state to state. You need to know what your State Practice Act states and what your state regulations and rules state. It's different state to state. And so as an evaluating telehealth therapist, you need to know what that says. So it's your responsibility to know. And if you don't know, then you need to reach out to your state board or to your state and get those answers. Like I said, it varies state to state. I can name a couple off the top of my head that you have to be in state. And then there are a ton that it does not matter. You can be out of state. I would say for the majority of them, you're allowed to be out of state. There's only really a few handful that I've come across where you have to be in state.
And the PT compact, really, and I'm a PT, which is why I'm bringing that up, but that's typically the easiest way to get those licenses so that you can operate in those different states. Prior to that, or if someone's not a member of the compact, you would have to go through all the steps to get a full regular state license, just like anybody else that's going to live there, so that you can practice in that state. But that's a great use for the PT compact.
And I want to just one quick thing here too. Not only do you want to check about the Practice Act for that, but also check what the requirements are for supervision. I know for one, partner with Minnesota, and all supervision has to be provided in person. So while an eval can be done via telehealth, supervisory visits cannot. So again, like Barb said, go back to your State Practice Act and read it, read it, read it.
Right. And also know if you are going to be responsible for supervising PTAs in that state, especially if you hold multiple licenses and you're a telehealth therapist, know what your supervision ratios are for your PTAs. They vary state to state. There are some that have no supervision ratios at all, and then there are states that have very strict supervision ratios. There are states that require you to make on-site visits every so often. So like we've been saying, it just really varies state to state. So you've got to know what the rules are.
Would OTs do simulated ADLs through telehealth? It seems odd to do a full bath and dress through telehealth.
Go ahead, Stephanie.
Obviously, there are going to be certain components that are not going to be completed via telehealth because of privacy issues. I don't do toileting tasks via telehealth. My assistants are completing those things, but I can do some simulated things with the patient to see how they do with functional reach for clothing management transfers outside of the restroom and things like that. So again, you got to use your clinical judgment there.
And we didn't have time to get to this question, but it's important that you make sure that the person that's doing the telehealth, you're in a closed room with no other family members, and that you let the person you're working with know that, so that they feel like they're in a safe and HIPAA compliant environment. Shyla, it looks like we've hit the top of the hour. Do we still maybe have time we can address one quick question?
Okay. Let's see. Can you be out of the country but licensed in the state where you're providing telehealth?
I know this happened. Who wants to take that one? Okay, just logically thinking, and I would talk to your compliance department about that, but if it doesn't specify where you have to be, if you don't have to be in that state, then, and you have a license in that state, I don't see why it would matter. But I cannot give you a definitive answer on that. I would get with your compliance department and ask.
One last question. Someone heard a PT compact and they were asking what that meant.
Oh, well, we don't have time for me to go through all that,
Oh,
but I can very briefly tell you. And this example is the easiest. Previously, if I wanted to help out in different states, I had to go through everything that you go through for that state, and I had to do all the CEU requirements in each of those states. Now, since I live in Arkansas and it's a PT compact state, so is Virginia and Kentucky, all I had to do was take a jurisprudence exam and apply on the PT Compact website. You can look that up and it will give you step-by-step directions, much cheaper as well. And within 30 minutes, I had a license for there. Now, check with your company because you may need to have a background check done for that, for each one of those. But as far as getting compact licenses, it decreases the expense and speeds it up. And the whole reason is that we need quick access to services. So yeah, just type in PT compact and that website will pop up for you.
okay. And that's all the time that we have. So thank you guys.
And don't forget about the housekeeping item that Shyla went over at the beginning. For OT speech, do your bubble sheets, and OT, you have a quiz that she'll send to you tomorrow. Right, Shyla?
Sure, that's correct. And if you have any other questions, you can send me an email. It was on the housekeeping slide, and I'll be happy to answer them or find out the answer if I don't know. So.
All right. Well, thank you all. Thank you to our wonderful panelists. And we appreciate everyone that joined today, and have a great evening.
Thanks, guys.
Bye-bye.